Yes.
Okay, sorry, I thought I was waiting for a signal. Okay. Good morning, Pat. Good morning, everybody. I'm very proud to be here. I'm sorry I couldn't be there in person, but Pat knows the story. She can tell you later. I hope you're looking at a slide and not at me that says health reform. Where is the Commonwealth now?
Yes.
Okay, so let's go on to the next one where I think we can just dive right in because I know we want to stay on time and get to the Q&A, which is the major point of this. Basically, I thought it was useful to go to slide 2 to review the reform climate so that people can remember, even though it's pretty easy, I guess, Virginia's a purple state. You know, it's voted for Obama twice. It voted to elect Democratic senators both times. When Webb ran, Obama got more votes. When Kane ran, Obama got less, but Obama did carry the state both times. Yet when McDonald ran in 2009, after the first Obama win, of course, he won pretty handily. And then in 2011, the Republicans gained enough seats in the Senate, in the State House, to have a split, which gives them de facto control on many issues because the lieutenant governor can break the tie, but the lieutenant governor, importantly, cannot break the tie on budget-related matters, and that'll turn out to matter for the Medicaid reform reality. Some of you may know that our elected Attorney General Cuccinelli was the very first Attorney General in the state to file a lawsuit against the ACA. It was later thrown out on sort of technical grounds. He didn't really have standing in the eyes of the appellate court, but nevertheless, it's a signal of a political force inside the Commonwealth. Pretty much at the same time, a couple of months later, the governor agreed to appoint a Virginia Health Reform Initiative Advisory Council, which was led by Secretary Bill Hazel, whom many of you know, as Secretary of Health and Human Resources, and that council met throughout the second half of 2010, and in December of 2010, made a number of recommendations to the governor and the legislature, which included the recommendation that Virginia should run its own marketplace or exchange, that is, not cede to the federal government control, but to take the opportunities in the Affordable Care Act to give Virginia a lot of choices, and second, to prepare for Medicaid expansion, and probably importantly, laid the foundation for thinking about delivery system reform Commonwealth-wide as something that needed to go along with the coverage expansions and marketplace changes, because there was pretty widespread agreement within the members of the advisory council that the single most important long-term issue is cost and cost growth control, and the pretty clear consensus was that's not going to be affected by insurance per se unless we do better at delivering better care for more people and so forth. So that was all part of the milieu going into the 2011 session. Then I think it's fair to say by the time the court ruled on the ACA in June of 2012, that was the first time that a lot of people had thought about the possibility that Medicaid was not a requirement. That is, the ACA said states will expand Medicaid come 2014 or suffer loss of their Medicaid program in total, and you all now know quite well Judge Roberts, in his wisdom, decided to, and by the way, he had support on this from, I think, Kagan and maybe Ginsburg. But anyway, the point is, the court ruled that Medicaid expansion was not required, that was too strong a compulsion to exceed the bounds of federalism, and so that made Medicaid a choice for the states, which created a different dynamic. And the reason I went through that first opening purple-ish milieu is to make it clear that folks who opposed reform philosophically, ideologically, never stopped opposing reform, even though the advisory council and a lot of what I will call elite opinion was moving in the direction. Folks seized upon this Supreme Court decision oppose what they call Obamacare, what I guess now everybody calls Obamacare, in the name of fiscal prudence for the state. And that is, there's no question that the context of healthcare discussions in Richmond in the State House, you cannot get away from the fact that Medicaid is one of the largest state budget items, certainly historically has been one of the fastest growing, and therefore when you mention Medicaid, a lot of people just have a knee-jerk reaction of saying, well, we got to cut spending, it costs too much. So the idea of avoiding an expansion of Medicaid was put forward as fiscal prudence for the state. And that argument has a lot of sway in certain circles. Well, the problem with the argument, of course, is that there are three facts that pretty strongly undercut it. One is the feds would pay 100% of the cost for the expansion population for the first 3 years, and then the federal match would phase down, but it would never go below 90% according to the law. The analysis that was done initially at the behest of the governor was shown to be not so correct, and so the analysis that was done in the last year, I believe it was released around January or I think January of this year, by the professionals at DMAS, showed that in fact Medicaid expansion would actually save the Commonwealth money for the first 5 or 6 years, and the cost after that would be relatively low compared to the very large economic benefit for the state. And that fact, that in fact the Medicaid expansion would reduce costs to the Commonwealth, got baked into the budget agreement that we'll talk about in a moment. And it's important because basically, if you assume Medicaid expansion will save money, you build that into your budget, then to vote against Medicaid expansion means you've got to fill the hole in the Virginia budget, and that turned out to matter at endgame in the budget politics this year. But the third fact, I think, which is in many ways a signal of, again, I'll just say elite opinion in Richmond, the Chamber of Commerce of the Commonwealth actually came out publicly in support of the Medicaid expansion, which means that was a signal, an important signal, that folks believe the economic analyses that were showing that indeed Medicaid would be very good for the state, it would be good for the state budget, et cetera, as opposed to the kind of analyses that were preferred by opponents of Obamacare from the beginning. Let's go now to slide 4 to explain where the Commonwealth is on the exchange. Some of you know that part of that Virginia Health Reform Initiative process with the Advisory Council, the council actually worked through and made a bunch of recommendations about how to run the Virginia exchange. Again, it had recommended that the Commonwealth run its own exchange, and the legislature actually sanctioned that view and asked the council to come back together and develop details of how the Commonwealth should run an exchange. To actually implement the recommendations of the council and the legislature, there needed to be some money, obviously, to build the exchange. That was the federal government made money available for that. It was called an establishment grant, and the proposal to apply for an establishment grant was completed, and the governor had indicated that he would sign it and they could submit it. But then when the Supreme Court ruled in a certain way, I think it's fair to say a lot of people who opposed the law in general, opposed Obama in general, were surprised, is a mild word, that the court ruled what it did. And anyway, just to make a long story short, the governor decided not to allow Virginia to apply for an establishment grant, which meant it was impossible for the state then to fulfill the recommendation of the Advisory Council, and it was impossible for the state to do its own exchange. The feds, in, I guess you'd say, reaction to the continued opposition to the law across the country, actually proposed a medium step of running the exchange, what the feds called a partnership, which would give the states two particular options, consumer outreach and plan management. The first is sort of obvious, the second not so much, but plan management really is the part of interacting with the health plans, um, uh, judging whether they have complied with various federal and state laws. It's the kind of thing you want done by professionals, and the feds were very much hopeful that the states who are not going to run their own exchange would at least do that, because the professionals inside bureaus of insurance around the country just wouldn't have to be trained in the way the federal workers would be. So, make a long story short, even though the governor refused to use the word partnership, which was the technical term created by the regulations to make this all possible under the law, HHS kind of winked and looked the other way and said, okay, fine, you can do plan management. We won't make you go public and call it a partnership. And so the Bureau of Insurance is now, as we speak, preparing to do those plan management functions. And so Virginia is effectively a partnership, even though the word will never cross anyone's lips. To go to the next slide, Medicaid Possibilities. Now this is really the denouement of all that stuff I talked about earlier, and this came about, frankly, rather late in the session this year. And I think it's fair to say that the possibilities of expanding Medicaid exist at this point for the Commonwealth in 2014 only because of two things. One was the fact that the Democrats had half the votes in the Senate, and remember, the lieutenant governor can't break a tie on budget matters. Therefore, in the budget deal, which was the final bill passed, the Democrats had leverage. And the second important fact was the governor really wanted a transportation agreement, and so the Democrats had even more leverage. And so basically the deal was cut to put an expansion of Medicaid into the budget. And remember now, when you do that, and the official DMAS estimates say that it will save the Commonwealth money for 5 years, then if you vote against that, and there were amendments to repeal that part, you have to put money back in the budget to make it balance. No one could do that, and so basically the expansion option survived. Now, there is a pretty important twist along the way, and that is the budget language coming from the House and eventually passed and signed by the governor created a new commission. Why not? We don't have enough. The commission is called the Medicaid Innovation and Reform Commission, or the MERC. It's already adopted its shorthand name. It has 12 members, Secretary of Finance and Secretary Hazel, Health and Human Resources, who are non-voting. But then it has 5 members from each house in the State House. And the law says that 3 of the 5 from each house, not just any old 6, but 3 from the House out of 5 and 3 from the Senate out of 5, must vote yes to the judgment that adequate Medicaid reform progress is being made in order for the expansion to go forward. So this MERC, this commission, will have its first meeting in June. I believe it's scheduled for June, August, maybe October, and then November after the election. That MERC will meet and review the progress that DMAS is making, and DMAS will be the main, I presume, presenter at their commission hearings, but maybe not the only one. And so basically this MERC will decide whether or not Virginia will expand Medicaid or not in a technical way. Most people expect them to wait until after the election for somewhat obvious reasons. But let's go to slide 6, and you will see the names of the delegates who have been appointed to the MERC. And I just put the counties or cities they represent here in case you don't know them. And I think you have these on your handout as well. And, you know, I would say if you care about Medicaid expansion, figure out how to talk to these people early and often. The next slide, slide 7, gives you the Senate appointees to the MERC, and you see Northern Virginia's own Janet Howell among them. But you may notice a preponderance of Republicans in both sets. I am told by authoritative sources that the Senate group is much more likely to vote yes than the House group. but I leave that to political professionals later on. Let's go on now to slide 8, which talks about the first set of things that DMAS, I think everybody knows what DMAS is, Department of Medical Assistance Services, the Medicaid program for the Commonwealth, the reforms they're pursuing in order to be compliant with the Merck. I will point out as quickly as I can that they were doing this anyway, and that essentially some of what the legislature demanded in terms of Medicaid reform was already very much underway. And so that's why I say on slide 8, reforms DMAS is pursuing statewide managed care, which went live this year, including for age blind and disabled and foster children, expanding the PACE program, various things around reducing the potential for fraud, improving, I guess you could say, assessment requirements for behavioral health, and then a major undertaking aligning incentives, which is the words the feds use for this, for dual eligibles. As you know, the frail elderly dual eligibles, that is people who are eligible for both Medicare and Medicaid, tend to be among the sicker, most vulnerable people in the Commonwealth, and they cost a lot of money, and coordinating care for them often can not only significantly improve patient health and indeed health maintenance, but also save either Medicare or Medicaid or both quite a bit of money. So a lot of attention is being devoted to them as a population across the country. There's a major initiative out of the federal CMS, and Virginia is one of a number of states that are participating in that. The next slide, slide 9, talks about what I call reforms that DMAS is planning. These are not yet underway, but very much in the end game of planning stages. Virginia is going to submit a very comprehensive 1115 waiver. That's a technical provision inside Medicaid that basically gives you, if you get the federal permission, that is, you are granted the waiver, gives you freedom to redesign various elements of the Medicaid program as long as it does so in a budget neutral way, and that's usually what the last round of debate and fighting is about. But a comprehensive 1115 waiver really does give, in my view, the Commonwealth and the Secretary and the DMAS leaders the credibility to say, look, we really are reforming Medicaid and we're focused on all the right things, improving patient care, improving quality, improving cost performance. And I think it's fair to say they are working as hard as they can through revisions in their contracts with the managed care organizations that cover the Medicaid population now, and always have covered, or have for a very long time covered, moms and kids, to using various incentives to improve quality and to basically impose some payment reform kinds of activities that we think, that a lot of people think, will improve outcomes. And then finally, to coordinate purchasing and delivery with the state employees and build on some other activity that I'm about to describe. So let's go to slide 10. One of the recommendations of the original advisory council to the Virginia Health Reform Initiative was to something like be a catalyst for this delivery system reform set of ideas between the public and private sector, as some people would say, the traditional Virginia way. So a 501c3 was created. Importantly and symbolically, it was housed at the State Chamber of Commerce. They give this center free rent as a signal to the stakeholders of Virginia, and I think it's important that they do that because, note, it led to immediate seed money coming from the major associations, the Hospital Association, Medical Society, Health Plan Association, so that everyone sees that the employers are engaged and behind this effort of bringing about improvement in the delivery system of Virginia. And this Innovation Center hit the ground running in December of 12 and now has surveyed providers around the state, has 6 task forces that are quite busy. I'm an advisor to one of them, creating proposals for initiatives coming out of CMS, the Center for Medicare and Medicaid Innovation, which is the new part of CMS created by the law to basically foment delivery reform and payment reform. And the initiatives are organized basically around the terms you see there at the bottom of slide 10, patient-centered medical home. Importantly, a lot of emphasis on integrating behavioral and acute care, on medication management, on care transitions, and then on consumer engagement in various ways. And then thinking sort of cradle to grave, a concept has arisen called bundles for babies, which is basically how to improve prenatal and postnatal and child health care throughout. The final slide with words on it is what I call summary, slide 11. Basically, I mean, as if I needed to do this morning, there's no question the actual Medicaid expansion decisions will depend upon the 2013 elections. The commission will surely vote. The commission will surely wait until the elections to vote. But even if they vote in a certain way, the new governor and the new legislature that will be elected in those elections will have total power to affect whether or not the Medicaid expansion goes forward, and everyone fully expects the decision to expand Medicaid to hinge completely on the outcome of those elections. And you can guess the predictions are associated with each candidate. The delivery reforms, however, I think it's fair to say will continue, and the federal exchange will come into the Commonwealth, and therefore some coverage expansion will happen in the Commonwealth. Not entirely clear how robust the competition will be in the federal exchange in Virginia. I'm sure some of you follow the national activities. There's a lot of excitement about the low premium estimates, lower than many naysayers had predicted in California, Washington, and Oregon. I do think there are some technical reasons why Virginia may not benefit from that sort of thing. But anyway, there will be a federal exchange. I'm confident it will enroll people, and it will potentially expand coverage to over 100,000 Virginians, according to some estimates that were done for the VHRI, even if Medicaid does not expand. But there's no question the bulk of the people who would gain coverage in the Commonwealth under the ACA would have gotten coverage through Medicaid, and therefore the Medicaid expansion is by far the biggest decision. And I think the larger question for Virginia, and I'll stop with that, is can collaboration replace individualism in time? Pat opened her talk by mentioning the individual partnerships for health in the individual jurisdictions in Northern Virginia, and I applaud her and her team for getting this full Northern Virginia Summit engaged so that we can start going beyond geographic boundaries, and that's symptomatic, in my view, of what the Commonwealth has always done. A lot of great folks, a lot of great institutions, wonderful providers in our Commonwealth in various places, but they tend not to work together as much as they work for their own individual gain, and there's no question in the modern era collaboration has a major role to play in improving our pursuit of the triple aim. I close with the very last slide just to let you see that Virginia is not alone in being somewhat flummoxed by which decision to take and which decision to make. This is a slide put together by the advisory board, which is basically a consulting firm for hospitals, but they do a decent job of conveying two things in this slide. One, whether states are leaning toward or already decided to expand Medicaid. That's the color of the map. Red is no, blue is yes. Anything else is sort of leaning one way or another. And then the symbols inside the states are what kind of marketplace or exchange has the state decided to pursue in the part of the ACA that's for folks above the Medicaid level but can't afford health care typically and completely on their own. The shopping cart is a state-run exchange. The Capitol dome-looking thing is a federal-run exchange. The handshake is a partnership exchange. And the map, you can look at Virginia immediately, is somewhat inaccurate because we do have a de facto partnership, although we dare not speak that name. And the map at the moment has us undecided toward Medicaid. I will just say it's hard, these maps are hard to do and to keep current. I stopped, and they stopped updating it as well in March. because, for example, the Florida governor and the Ohio governor support Medicaid expansion, even though they are pretty strong Republican spokespeople for the conservative point of view, but their legislatures have pretty much stopped the possibility of Medicaid expansion in those states. So, in fact, those states should be red. I personally would color Virginia at this point more pink, that is leaning toward reform, because the budget language pushes in that way. But like I said, it really does come down to the election. Thank you very much. I appreciate the opportunity to be here. I'll be quiet now and stay around for Q&A later.
Thanks, Lynn.